Imagine needing to really get your head around a complex medical condition, maybe like inflammatory bowel diseases, IBD, ulcerative colitis, Crohn's disease. You want the key insights, the stuff that really matters, but without uh, wading through dense medical texts. Well, that's exactly what we're doing today. We're taking a deep dive into some critical new insights. These come from a really important publication, the Asia-Pacific Association of Gastroenterology Consensus Statements on Histopathological Evaluation of Inflammatory Bowel Diseases, Liang et al., published in 2025. And this isn't just, another paper, it's a guide, carefully put together by international experts, specifically thinking about the Asia-Pacific region. Our mission: to unpack how looking at tissue under a microscope, histology, that's the term, is becoming, well, an increasingly powerful tool. It's not just for diagnosis anymore. It's guiding treatment, predicting how things might go, and even looking at the potential of AI in patient care. This deep dive should give you the clearest takeaways, maybe even some surprising facts so you feel properly informed.
Exactly. It's fascinating, really, to see histology moving beyond just that initial diagnosis.
Yeah.
It's becoming so dynamic, directly shaping how patients are managed. And these consensus statements, they give us a sort of harmonized framework. That's incredibly important for a region as diverse as the Asia-Pacific,
Yeah.
where, approaches can really vary.
Right. So to really get why these statements are such a big deal, maybe we should first talk about why histology has become this game changer for IBD management. Because as you said, IBD covers ulcerative colitis and Crohn's. These are chronic inflammatory conditions, and unfortunately, they can seriously impact quality of life, often need ongoing treatment, sometimes hospital stays, even surgery. It's a tough thing for patients globally.
It really is. And historically, histology's always been there as this objective, pretty effective tool. It helps with the initial diagnosis, sure, but also assessing severity, seeing if treatments are working, and sometimes even giving clues about how the disease might progress. It gives us this really precise cellular level picture of what's actually going on inside the gut lining.
Okay, now this is where it gets really interesting, especially with this Asia-Pacific focus. You mentioned the need for clear guidelines there. Why is it particularly pressing in that region?
Well, there are a few key reasons. First, how common IBD is can vary a lot between countries in the Asia-Pacific. Resources differ too, sometimes quite significantly. And crucially, there's often a bigger challenge distinguishing IBD from infectious enterocolitis. That's inflammation from infections, which can look very similar symptom-wise.
Ah, so it can mimic IBD. That sounds like a potential diagnostic headache without clear guidance.
Exactly. A real puzzle sometimes. So this consensus is really aiming to get everyone on the same page. It's about harmonizing how histology is used, how the samples are handled, processed, and how the findings are reported across the whole region. The goal is to make it a much more consistent and therefore more powerful tool for everyone involved, clinicians, pathologists, wherever they're working.
Makes total sense. Getting that consistency is key. But how did they actually do it? How did these experts decode the, microscopic language of IBD and agree on these statements? What was the process?
It was pretty rigorous. They started with a very thorough literature review, looking at everything published up to January 2023. Then this international group, gastroenterologists, histopathologists from places like Australia, China, India, Japan, Singapore, many others got together. They used what's called a modified Delphi method. It's a formal process where experts vote anonymously on statements over several rounds. Helps build consensus without individuals overly influencing things. They started with 38 statements and actually reached consensus on 37. That shows a really high level of agreement among the experts.
Wow, 37 out of 38. That is thorough. Okay, so let's dive into the specifics then. For ulcerative colitis UC, what are the key things a pathologist is looking for? What signals active disease?
Right, for active UC, the main feature is neutrophilic infiltration. Basically, neutrophils, a type of immune cell moving into the colonic lining, the epithelium, or the lamina propria. Think of them like tiny soldiers rushing to the site of inflammation. The more you see, the more active the inflammation. And this can progress, It might start subtly as cryptitis, that's inflammation in the colon's crypts. Then it can develop into crypt abscesses. And eventually you might see erosions or even ulcers in the lining.
Okay, so neutrophils are the sign of active fire, but what about the long-term damage? What signs show that UC has been there for a while, the chronic changes?
Good question. Long-term UC leaves its mark too. The main sign of chronicity is crypt architectural distortion. This means the crypts, these glands in the colon lining, lose their normal shape. They might become branched or shrink, which is called atrophy. You might also see other things like Paneth cell metaplasia or fewer goblet cells. These all point to tissue remodeling from that ongoing chronic inflammation.
And remission. When things are quiet, when a UC patient is doing well, what does that look like under the microscope? Is everything back to normal?
Well, histological remission in UC means those active signs are gone, no more erosions, ulcers, or that neutrophilic infiltration we talked about. But, and this is interesting, those signs of chronicity, like the distorted crypts, can actually stick around, even when the active inflammation is resolved.
Ah, okay.
So, it highlights a key point. You can have leftover structural changes from past damage, even if the active disease process is currently quiet.
That's a really important distinction. So moving over to Crohn's disease, CD, how does it look different microscopically? Are there unique markers compared to UC?
For CD, it's similar in some ways. Neutrophilic infiltration still signals active disease, and you also see signs of chronicity, like crypt distortion and chronic inflammatory cells. However, there's a key nuance, particularly regarding granulomas.
Granulomas are often linked to Crohn's.
They are, but the expert panel agreed that finding granulomas doesn't specifically indicate histological activity. You can find them in other conditions too, like TB or sarcoidosis. So just seeing a granuloma doesn't automatically mean that Crohn's is actively inflamed right then and there. Also, another point for both UC and CD seeing eosinophils, another type of immune cell, isn't considered specific for active disease either.
That's actually quite surprising about the granulomas. I think many people, maybe even some doctors, automatically think active Crohn's when they hear granuloma. But this consensus clarifies it's not a specific marker for activity. That really changes the interpretation. So, okay, putting this all together for you, the listener, does looking at these microscopic details actually help predict if the disease might flare up again, relapse?
Yes, definitely. For UC, both the active histological signs and those chronic changes can predict a clinical relapse down the line. In fact, there was a big meta-analysis pooling data from many studies. It showed that features like neutrophilic infiltration increased the odds of a relapse by about 2.3 times.
Wow, 2.3 times.
It's significant. And for CB, the evidence is still building, but achieving histological remission itself seems to predict a lower risk of clinical relapse. So yes, these microscopic findings have real predictive power for a patient's future course.
That's huge. For UC patients, that means getting to histological remission could, potentially cut the risk of needing more steroids, hospital stays, maybe even surgery. It's not just about diagnosis, it's predictive. Which leads us to, how do we make sure this powerful information is gathered and interpreted consistently? It sounds like having the right expertise and the right reporting process is vital.
Absolutely critical. Ideally, the person looking at the IBD biopsy slides should be a specialized gastroenterology pathologist. Having that specific expertise really helps reduce disagreements between different pathologists looking at the same slide. It leads to more consistent, reliable interpretations.
And the report itself, the piece of paper or digital file that comes back, does it need a specific format?
Yes, the consensus strongly recommends using standardized synoptic pathology reports. It means they're highly structured, using checklists or templates, so the information is presented consistently every time. These reports should include both descriptions and a validated scoring system. We'll probably touch on those later. And importantly, they recommend avoiding vague terms like non-specific colitis or indeterminate colitis whenever possible. The aim is precision.
Okay, more precision. And what about the information going to the pathologist? If I'm having a biopsy, what does my doctor need to tell the lab? Is that context important?
Hugely important. Your doctor's role here is crucial. The request form that goes with the biopsy needs relevant clinical details. Things like why the biopsy was taken, the exact location of the gut, how long you've had IBD, what the doctor saw during the endoscopy, endoscopic activity, and any specific concerns like infection or previous dysplasia, which is precancerous change. Giving the pathologist all that context really helps them make the most accurate interpretation. It's a team effort.
Right. Better information in, better information out. And the actual samples, the biopsies themselves, are there best practices for taking them?
Yes, clear guidelines there too. Segmental biopsies, meaning samples from different parts of the colon, should be taken both at the first diagnosis and during follow-up scopes. This helps map out the full extent of the disease. If there's obvious inflammation or an ulcer, biopsies should definitely come from the most active-looking area or right from the edge of an ulcer. And generally, the standard stain called hematoxylin and eosin or H&E is usually enough. But special stains can be used if the doctor suspects a specific infection, like CMV or TB.
Got it. So we've covered identifying features, standardizing reports, and biopsies. But how do we actually measure the activity, put a number on it? This seems crucial for tracking progress. Let's talk about scoring disease activity and this idea of combined remission.
Exactly. To make things objective and comparable, several histological scoring systems, or indices, have been developed. The main ones mentioned are the Gibo score, GS, the Robarts Histopathology Index, RHI, and the Nancy Index, NI. These all have defined cutoff points for what counts as histological response or full remission. And generally, they correlate pretty well with each other, which is reassuring. They give clinicians a solid way to quantify the inflammation.
Okay, several options. Is there one that's maybe preferred, especially for UC?
Well, what's interesting here is that for ulcerative colitis, the consensus highlights the Nancy Index, the NI, as probably the preferred one for routine clinical practice, though, it's still being validated further. It's quite simple, just a 0 to 4 scale. 0 means histological remission, basically, little to no inflammation. A score of 4 means there's erosion or ulceration. The reasons it's recommended: it's been well validated, correlates robustly with other scores and endoscopic findings, and it's relatively simple to use.
Simplicity is definitely a plus in a busy clinic. But what about Crohn's disease? Is there a go-to scoring system for CD histology that's widely accepted?
That's actually a key point where more work is needed. For Crohn's, there isn't currently a single, well-defined histological scoring system that everyone agrees on. It's still awaiting further validation. So while some scoring might be used, there's no consensus yet on a preferred index like the Nancy Index for UC. It's definitely an active area for research.
Okay, so scoring helps quantify things, especially in UC with the Nancy Index. But let's get back to the big picture impact. Does achieving this histological remission, getting that score down to 0 or near 0, actually matter for patients long term?
Oh, absolutely. The prognostic value, what it tells us about the future, is incredibly significant, especially in UC. Achieving histological remission in UC is linked to a much lower risk of needing corticosteroids later, fewer hospitalizations, and even a lower chance of needing a colectomy, which is major surgery to remove the colon. Studies have shown something like a 63% reduction in the risk of clinical relapse for patients who get to histological remission compared to those who still have active inflammation under the microscope.
63%.
It's a major difference. It suggests you're really altering the long-term course of the disease, not just managing symptoms day to day.
That's a massive impact. And for Crohn's, even though the scoring is less settled, does achieving histological healing still provide benefits?
Yes, even with the scoring challenges, the evidence suggests it does. For ileal Crohn's, that's CD in the last part of the small intestine, histological healing seems to be more strongly linked to better long-term outcomes than just endoscopic healing alone. Better outcomes like reduced relapse rates and less need to escalate medications.
So it's like endoscopy shows you the surface looks okay, but histology confirms the foundations are solid too.
That's a great analogy, yes.
Yes.
It's a deeper level of healing, and it seems to be more predictive of future stability.
So connecting the dots, it sounds like the ultimate target, the real gold standard, might be achieving both kinds of healing together, looking good on the scope and under the microscope.
Precisely. That's the key message. Achieving both histological and endoscopic remission gives you greater prognostic value than just endoscopic remission by itself. In fact, the very definition of mucosal healing is evolving to require assessing both. You could, for instance, have an endoscopy score of 0 looks perfectly fine to the eye, but still have some lingering microscopic inflammation. This consensus makes it clear. Even in that situation, getting rid of that microscopic inflammation, achieving histological remission too, gives you an even lower risk of relapse. That combined remission is really the target now.
Wow. Okay, this level of detail and aiming for combined remission, it sounds like managing IBD effectively requires a lot of different expertise working together. Which brings us to the human element and also the rise of AI. Does the consensus talk about team structure?
It does, very clearly. It strongly recommends including a dedicated GI pathologist, someone specializing in gut diseases, as a core member of the multidisciplinary team, the MDT.
Why is that specific role so important?
Well, integrating the pathologist directly into the team discussions has a real impact. One study they cited showed it actually changed the diagnosis or the management plan in over half the cases discussed.
51%.
Yes, and it led to 70% of those patients achieving clinical response or remission. So it's not just about getting the pathology report right. It's about integrating that expertise into the clinical decision-making. Plus, it fosters collaboration. Everyone learns from each other.
Makes perfect sense. Now, the really futuristic part, artificial intelligence. How is AI starting to fit into this picture, especially in something as complex as histology?
AI is definitely an exciting area. The consensus notes it can significantly improve assessment of both endoscopic and histological disease activity in IBD. We're seeing AI models with high accuracy, for example, being able to distinguish between UC and CD just from endoscopic images with like 96% accuracy per patient in some studies. And for histology, AI could potentially enhance the workflow for pathologists, maybe improve their accuracy or speed, helping them manage the workload, especially for complex cases.
So efficiency and maybe even diagnostic help. Could AI assist with detecting really critical things, like early signs of cancer risk that might be easy to miss?
That's a major area of promise. AI hold high potential for detecting colitis-associated dysplasia, those precancerous changes, especially the flat lesions, which are notoriously difficult for the human eye to spot reliably during standard colonoscopy. If AI can flag those earlier and more consistently, that could be a huge benefit for preventing cancer development in IBD patients.
That really could be a game changer. But it does raise the question many people have about AI in medicine. Is the goal for AI to replace the human experts, the pathologists in this case?
The consensus addresses this directly. The view is very clear. AI is not meant to replace pathologists.
Yeah.
The goal is to enhance their capabilities, to provide complementary support. Think of it as a powerful assistant, an ally that helps the pathologist be even more effective and maybe focus their expertise where it's most needed.
An assistant, not a replacement. That's reassuring. Okay, we've covered a huge amount of ground, but like any deep dive into complex science, there must have been areas where the experts didn't fully agree, unanswered questions.
Yes, despite reaching consensus on 37 statements, there was one significant area where they couldn't agree. It was about whether treatment should be intensified, like adding a new drug or switching to a stronger one solely based on finding histological activity, even if the endoscopy looks fine.
That's a really practical, important question for treatment decisions. Why couldn't they reach consensus on that? What were the main concerns or sticking points?
There were several reservations. Firstly, there just isn't enough high-quality evidence right now to support changing or escalating therapy only because of microscopic inflammation, especially if the patient is otherwise doing well and the endoscopy looks okay. There were also concerns about the extra costs, the potential side effects or toxicity from adding more treatment, and the fact that histological healing might just naturally take longer and might lag behind endoscopic healing. So, jumping to escalate treatment based only on the histology might be premature or unnecessary in some cases. It really highlights a key knowledge gap we need to fill with more research.
That makes sense. It's a balance between aiming for the deepest healing and avoiding potential overtreatment. So, given that uncertainty, what do the experts suggest clinicians do in that situation?
The working group recommended a more cautious approach for now. They suggest maybe repeating the histology later to see if that delayed healing happens naturally. Also, checking if the patient is actually taking their current medication properly, non-adherence is common. And trying simple things like optimizing the dose of the current therapy first. Basically, explore other options before escalating to stronger or additional treatments based only on the histology result. It really points towards needing more prospective studies to figure out the best strategy here.
Okay, so a cautious approach while we wait for more evidence. So let's try and wrap this up. We've really journeyed through the evolving world of IBD histology today. We've seen it go from mainly a diagnostic tool to something central in managing the disease, predicting outcomes, guiding biopsies, standardizing reports with things like the Nancy Index, especially for UC. We've
Mhm.
talked about the huge prognostic value of achieving that deep histological remission, particularly when it's combined with endoscopic healing. And we touched on the importance of the multidisciplinary team, including that specialist pathologist, and the really exciting potential and current role of AI as an assistant.
Absolutely. It's clear histology is becoming much more precise, much more integrated into personalized IBD care.
It really is. This deep dive shows histology as this incredibly dynamic field, constantly refining how we see and manage IBD to improve patient lives. So maybe the final thought to leave you with is this. Considering those significant benefits we discussed, especially the prognostic power of histological remission in UC, how might the future research, particularly on that tricky question of when and if to intensify treatment based only on microscopic findings, how might that eventually reshape IBD management across the globe? Could it push us towards even more tailored, maybe even more aggressive treatment strategies earlier on to achieve that deep healing? That's definitely something to watch.